Right, everyone out there. Good. Gosh, but I am there. So it's Courtney. That's what Courtney looks like. I was curious. Oh my God. It's exactly how I pictured you. That's a funny thing with COVID when you saw people. Wasn't it weird seeing them without their masks? Because my mind could not predict what a chin looked like. It's like you never did that your entire life. Like other people, you can kind of see a difference. So people take their masks off and be like, "Wow, you look completely different than I thought you would," because they have different chins or different things. It's always a weird thing to see their faces after a while because the mind couldn't fill like my mind couldn't fill that gap in.
You got to get more creative, Dave.
I am not creative.
Get yourself out of the clinic once in a while.
Yeah, there was a tech that I didn't recognize him for about 10 seconds when he had the mask off because he had like a beard. I didn't know he had a beard.
Just keep asking him who he is and what he's doing.
Exactly. There's like, that's just the old guy in the clinic. Can't remember everything, to tell me he had lunch today.
Sounds about right.
Good.
Still want to do force output stuff today?
Absolutely.
All right.
I'm looking forward to it.
I got my thing queued up here, so we should be good to go. Have any housekeeping issues? Anything you need to go over first?
Now, there'll be probably one thing I will send out. You guys, you have the hour by hour, the course manual. If you go there, I am updating it as we go. I'm going to rebuild Sunday a little bit. Eric, what I was thinking about doing is just, they're all burnt out by the time I get to the hip anywhere in Sunday afternoon.
Yeah.
So I was going to flip and go like hip to SI joint on Sunday just to see, does that work and flow a little bit better? So the hip's not coming so late. I feel like by the time you get there, I always underserve the hip on that day. This is what I've noted in the prior courses. So
Yeah, I don't necessarily disagree. I mean, I think it's probably going to be the case for whatever you get to last on most Sundays,
exactly.
especially module one when it's kind of a new thing and a lot of
Hmm.
stuff being thrown at you. But so it's just kind of a matter of which one you want to
Yeah.
spend the
So
focus on, if it's the
I'll
hip or
flip
the
that a little
SI or
bit.
whatever.
We'll see. I'll let you know how it goes or doesn't go, but I think it's exactly what will happen because then you have SI in five. So I think we can get back to it or the other ones.
Yeah, spent a lot of time in five, so on
Yeah.
SI joints. So
So that's just kind of the one housekeeping things. You look at that. I'll be rearranging just a couple things, and I'll be sending you one thing to. On Friday, I had basically the neurophysiological effects of manual therapy, an article. I'm probably going to bump that to online, and then we'll probably cover more radiculopathy and referred stuff on the Friday slot. So that's just the two adjustments I'm making to the weekend schedule.
that's all good.
But all you people out there, don't fret. You'll be good.
It's all the same material. It's just a matter of which comes first. So
Mhm.
not a huge issue. I got another email from Britain, so make sure
Mhm.
she gets
I
the
got her. Yep, I'm
agenda.
on her.
All
Go
right.
for it.
I'm gonna go ahead and pull this up here. Got to get everybody's faces out of the way. There we go. All right, ladies and gentlemen, today um, we're talking about something that's kind of near and dear to my heart here with the force output theory and concept. Um, Basically, most of you will look at this as strength testing. I don't like the term strength testing simply for the fact that we're not necessarily always testing for strength. In most cases, we're going to be looking at power, palsy, or pain when we're testing specific musculature. Pain should be a pretty obvious thing. We're just looking for reproduction of the patient's discomfort that they come in with complaints of. Palsy, um, this is one of those concepts that I wasn't very good at when I came out of PT school when I started taking these courses uh, you know, decades ago. But we're looking more for fatigability, loss of neurological input and output, right? So we'll talk more about what that actually looks like and what the characteristics of that look like as far as force output testing. Power, I'm not a huge fan of that terminology either. I'm a bit of a gym rat, so power to me is always the ability to generate strength in a certain amount of time. Um, so how quickly you're able to generate a contraction. So I don't necessarily like the term power, but because we have to look at the ability of the neurological system to contribute, of the neurophysiological system to contribute via joint mechanoreceptors, muscle spindles, GTOs, all the different length tension relationships, things of that sort of nature. And then the mechanical components. Is the leverage what needs to be there in order for a muscle to function properly? So force output's kind of just the terminology that I've thrown on top of this sort of thing. Um, as a way of making a little more specific to our goals as physical therapists, particularly for this um, cohort, right? So go ahead and move on here, maybe. There we go. All right. So general definition of this thing, force output is just the ability of the neuromuscular system to generate a resistance to any given load. Okay, some sort of external load. Now, we talked a little bit about some of the factors that play a role here. Fatigability versus non-fatigability. Basically, what fatigability is it should be exactly what it sounds like, is the muscle gets weaker under repetitive or sustained resistance. Okay, so that's very important. That's something that we'll talk about in depth when we get into some of the neurological components that go along with force output testing. Speed dependence is another very big one. It's not something that I think has been adequately proven via research. When we look at it, we're looking at more of the ability of the body to absorb load under a certain amount of speed that load comes at you. So it's very important for athletes, for dynamic movements, that sort of stuff, in order to be able to help stabilize particular joints, in order to be able to produce a certain amount of force in a certain amount of time. Pain response obviously is a big one. If a joint or a muscle tissue, contractile tissue is painful, it's not going to be able to generate the same amount of force. Leverage, like I mentioned, basically that articular integrity. Is the joint sitting in kind of its neutral position? And if it's not, will it still be able to produce the adequate amount of mechanical response? And most cases it won't be. And that again gives us a very particular characteristic to the resistance that a patient is able to give us when we go to test these things. Regional dependence is a relatively new thing that we've kind of talked about over just the last, I don't even know how long to say, maybe
Mm.
5 years or so. And this is really based more off of anchoring, the ability of the body to anchor basically one of the girdle mechanisms against the trunk. Okay, so this technically is mostly going to affect the shoulder girdle,
Mhm.
the pelvic girdle, and the hips. Basically, if we don't have an adequate anchor system, adequate foundation for these muscles to be anchored to the trunk, we're going to develop a very consistent, but also very noticeable breaking weakness that occurs. Very similar to the sort of thing that we're going to see with a reflex inhibition, which is more specific to a local joint. Regional dependence like this is something like if we were to try and test the rotator cuff in various positions of the arm, we'll find specific weaknesses that will occur across multiple muscle groups that are not segmentally consistent and that are not specific to one particular local joint. Okay, so we'll talk more about that as we go. But it is another thing that we have to be aware of because it is a phenomenon that we do see in clinic. All right. So here's kind of the nuts and bolts of this thing. So force output problems, right? So this is essentially somebody that we're testing in the clinic and they're not able to give us an adequate resistance. Okay. And we'll get into the process of how I go through force output testing when we get here toward the end. But I want you guys to understand some of these um, issues that may come up that will give us deficits in strength. Okay, so the first one, and this should be a very familiar one to most people, we'll probably have some other thoughts on this that are different from what you've heard or seen before, but radiculopathy, this is obviously caused by loss of conduction in an affected nerve root. Okay, so this is a very segmental issue that should be occurring if we're finding it in clinic. All right, so a fatigable weakness. Okay, so we talked about this just a second ago, but the idea here with the fatigability is that it will get weaker with either a sustained, so a maintained contraction, or repeated testing. Personally, I will prefer repeated testing, and I'll go over a little bit of why that is as we go through this whole thing. Um, but we should see if we find fatigable weakness, we should see it present, especially with the radiculopathy, with other neurological signs. Okay, that would mean either a loss of sensation or diminished reflexes. Okay, now the sensation loss is going to be pretty poorly defined. Okay, so the reason for that, meaning the borders of where this sensation loss is, they're not going to be very consistent. If I test a particular area once, patient may say, no, I don't feel that. And if I test that exact same area again, 2 seconds later, they may say, yeah, okay, I do feel that. So ill-defined borders is very pathognomic of a radicular neurological loss. Okay, and the reason for that is there's a lot of overlap between the dermatomes. Okay, so when we're looking for sensory loss, what we'll tend to find is that the sensory loss is going to be most consistent. I can't stress that enough, most consistent at the very distal end of the dermatome. Okay, so if I'm testing the lower extremity and I'm looking at L4 sensory testing, it's going to be most consistently loss across the tip of the big toe. L5, more likely the middle toe. S1, the pinky toe, and kind of the lateral border of the foot. These are the most distal areas of those particular dermatomes. So they're going to be the most likely areas where there's not going to be any overlap. Okay, if we start testing further up the dermatomes, there may be enough overlap from the adjacent dermatomes that we may not find consistency there. But that's important to recognize because it's different than what we would see with a peripheral neuropathy. Okay. Radiculopathy should also present in a segmental pattern. And what that means is when we're doing muscle testing here, force output testing with the aim of finding a radiculopathy, we can't only test one muscle. It doesn't give us the answers that we're looking for. If I test, so let's stick with the lower extremity here. If I'm testing L5, and the way I will typically do it is I'll start with hallux extension as my L5 key muscle. If I find a fatigable weakness there, I can't use that specifically as a loss of L5 conduction. Okay, I have to test another L5 key muscle that does not have the same peripheral innervation. Okay, so I have to go up and maybe do something like testing the hip abductors because they have different peripheral innervations, but the same segmental innervation. Okay, so if we find fatigable weakness, any of these issues that should be considered segmental, we have to go back and test another segmental muscle, key muscle, to give us the idea that yes, this is presenting in a segmental distribution and not a peripheral distribution. Okay, so that kind of leads us right into a peripheral neuropathy. This is basically the same issue, but it's caused by the conduction loss in a peripheral nerve. Okay, so this would mean compression or neurological damage more distal than at the nerve root. Okay, so we see this a fair amount. Most of us have experienced just banging our funny bone, the ulnar nerve on something, and we get that tingling, those paresthesias. Those sort of things are very consistent with peripheral neuropathies, right? So should still present with a fatigable weakness, right? This is still a neurological loss, so the fatigability should still be there. There may or may not be a loss of sensation associated with this. This will depend on whether or not it is a mixed nerve. Okay, there are certain neurological components in the body that have only motor components and certain ones that only have sensory components, right? So looking at, say, the sural nerve in the lower extremity is a sensory only nerve, right? Doesn't have any motor components. Looking at the musculocutaneous nerve in the upper extremity, same sort of idea, just the reverse. It's mostly a motor component, right? So similarly with the subscapular nerves, things of that sort of nature, they don't have any sensory components, right? So they're motor only. Okay, the biggest difference that we'll have here with the sensation stuff, if we do have a mixed nerve and there is potential for sensation loss, is it will have very distinct borders. Okay, peripheral nerves are very specific about what what portions of the skin they innervate. So we will have much more distinct borders that we can map out with not just light touch testing. Usually we'll use a tissue or of something like that, a cotton ball, something along those lines for light touch. And then in order to map out the periphery of that sensory loss, we'll use something like a paper clip or something along those lines that has a little bit more of a sharp edge to it. So using sharp dull is much more effective method of mapping out those borders. So if we have distinct borders, consistent borders, we're probably looking more at a peripheral neuropathy than we are with a radiculopathy. Okay. Should present in a non-segmental pattern, meaning it should be consistent with the peripheral distribution. So for instance, if we're looking at a palsy of the radial nerve in the axilla, right? So up here under the arm, we would have weakness of the triceps, which would be C7, wrist extensors, which would be C6, as well as the thumb extensors, which would be C8. Okay, so that suggests multi-segmental problems, which is very bad news if we're looking at that in the cervical spine. Anything more than one particular level in the cervical spine being affected is considered a red flag. That patient should not be treated, shouldn't even be further evaluated if you start running into that. But when we're looking at this, we can say, okay, these are all radial nerve muscles. They just happen to have separate innervations from a segmental perspective. Okay, so we have to be able to make that association in order to continue on. Otherwise, if we're looking at three particular levels of the cervical spine that might be affected by a particular pathology in the neck, no good. That patient needs to be out of your office, needs to be evaluated medically. Okay, now here's one of the things. It's down here on the bottom. I'm not sure if you guys will be able to see it real well or not. One thing that I always like to discuss about palsies is they are not typically manually detectable until we've already lost about 80% of the motor units, the conduction to the various motor units within that muscle. Okay, so a normal muscle contraction only fires about 60% of the motor units in a muscle. And it does, the body does this to save muscular effort in reserve for sustained or repetitive contractions, right? So if I have to carry something that's relatively heavy and it's going to take longer than say 6-7 seconds for me to carry it, I have to have something to carry over so that that muscle is able to maintain that contraction so I don't drop what it is that I'm carrying. Okay, so that's why we have this 40% reserve that typically happens with a normal muscle contraction. Okay, now in any particular contraction, we can get a full contraction with only about 10 to 15% of the motor units firing. Meaning if I go to test the person on the very first try, and they only have, say, 10% of those motor units firing, they're going to be able to give me one good resistance. The second time I go to test them, there's nothing left to carry over to. Okay, there's no motor units left in reserve. There's not enough conduction left to fire the remaining motor units. So the thing's just going to fall apart. So when we get to the process, we usually say the first 1, 2, 3 repetitions that we do with repetitive muscle testing, we're testing for fatigability. But I'll tell you this right now, in most cases, you're going to find that fatigability by the second repetition because of how weak these things have to be already, having lost at least 80% just to have this be manually detectable. That second repetition is going to be pretty limp. There's not going to be a whole lot there. Okay. Any questions about any of that before I move on?
Yeah, this is really nice because it really helps clear your thought process up when you're getting clinic because you start to see somebody like, man, I don't know what's going on. Being able to work through this really can clear up a lot and have things make sense, So this is something that's really worth dedicating a little bit of time, even if you're at the point a year from now, like, oh God, I don't remember the levels, knowing that I want to differentiate the radiculopathy from the peripheral neuropathy is super helpful to have in your mind. And that idea of looking at L5 at two different areas or any muscle for that standpoint at two different points is super helpful in discriminating what your problem is. But it also gives you clarity of thought, which in some ways is the most important thing because then you're not kind of confounded as you're going through your eval, which makes it a frustrating process. Knowing this, you can kind of really move through things systematically to, really get to the heart of what's going on faster, which gives you more confidence.
Sorry,
The
I'm
only
just looking at
question
the
you have, Eric,
chat.
is
So the only question I saw that was kind of specific to me was, how long do we hold each contraction? We'll talk more about it as we get to it, and it'll certainly be demonstrated in lab and whatnot. But the idea here is to build up a slow buildup on that first contraction, right? So we want to get our hands on whatever stuff. Usually I use the ankle dorsiflexion as kind of the obvious choice. It's just an easy one to get good leverage on. Get your hand onto that, and you're going to build up that resistance for about a beat of 2 seconds or so. That doesn't burn through all the ATP that muscle, that those motor units have, so we're not going to break right through it. But it's not so fast that we're going to trigger any of the neurophysiological mechanisms that we're going to talk about still from there. Okay, so slow buildup, but consistent resistance. Okay, moving on. Maybe. There we go. Okay, now axoplasmic flow. This is a neurological issue, and has neurophysiological components to go along with it. This is one of those things that years ago we didn't even bother introducing until we got into like module 7. So basically, like a year and change from now would be the first time you'd be introduced to this thought. I always had issues with that just because of the fact that this is a relatively complex concept. Um, and so I think the longer you have to kind of take it and think about it and digest it, the more likely you are to consistently understand it and be able to apply it to the patients that you see in the clinic. So don't get too worked up if it doesn't make perfect sense here after one hour of discussing this stuff. This one is a relatively complex mechanism that we have to kind of spoon feed a little bit early on. Okay, so what axoplasmic flow is, there's actually technically 3 types of axoplasmic flow. There's 2 anterograde versions, and then there's a retrograde version. The retrograde version we don't get too concerned with when we're talking about force output, because it doesn't have anything to do with force output. So as far as this goes, for the anterograde flow, there's 2 types. We have fast anterograde flow and slow anterograde flow. Okay, fast flow is about 400 millimeters a day, meaning that's the distance that it's able to travel. What it does is it delivers things like neurotransmitters, different proteins, mitochondria, things of that sort of nature that help to perpetuate the transmission of signals across the synapse. Okay, so you can kind of see how this would also produce a fatigable weakness. If we run out a neurotransmitter that's not able to now bridge that synapse, the contractions are going to stop, right? So that makes a lot of sense to me. Hopefully it does to you guys as well. Typically with this, this is not associated with a loss of sensation or reflexes, just because the sensation is that afferent mechanism that's coming back up the nerve, more of a conduction thing. It doesn't necessarily affect that. And reflexes require both the sensory and the motor component. So if we still maintain the adequate sensory components and we still are able to produce that first contraction like we would with a radiculopathy within that first 10%, 10, 20% or so, we'll still be able to get a reflex reaction out of these regions. I always look at this stuff as a component of what we might see with a notable double crush syndrome. Okay, everybody's probably heard the term double crush at this point in their careers. Basically, there's multiple sites of compression and or tension along the length of a nerve. Okay, so we could have a subclinical compression site here in the cervical spine, meaning it's not enough to affect conduction in and of itself. But what it does is it starts to slow that axoplasmic flow down. Think of a drain that has multiple clogs to it, right? We're trying to get this down the system here in order to get to the end organ and get that end organ to fire for us. If we get something that kind of starts slowing that down, that axoplasmic flow down here, and then say we have a secondary compression or tension site underneath the collarbone or here at the elbow, or at the carpal tunnel, Guyon's canal, whatever the point may be. If we start to have multiple compression sites, that flow continues to slow down after each compression, if that makes sense. So what we tend to see is this will start to develop weaknesses beyond the most distal compression site, right? So if I have an issue here that's subclinical, an issue here that's subclinical, and then an issue at the cubital tunnel in my elbow, it's usually beyond that cubital tunnel that I'll start to see these weaknesses, this fatigable weakness start to demonstrate itself, right? So that's where we'll start to notice it. And that's something that we have to be able to test for. Now, I will tend to say in most cases, we will have neurological tension associated with double crush syndromes. This means upper limb tension tests will tend to be positive. And I'll tell you this from years and years of experience of looking at this sort of thing, it is very consistent that it's the median and radial nerves that are most consistently tensioned. Not that we can't have issues in the ulnar nerve, but for whatever reason, if we have multiple compression sites, it does not tend to have the same tension associated with it. So when we're looking at things in the lower extremity, like a slump test, and we can't really bias it as well, we just tend to have less extensibility of that neurological system in a slump position. And again, the slump test is something that we'll go over. Same thing with the straight leg raise, these different things, more in the lab setting with you guys. Okay, but that is another way that we can look at this and say, okay, this looks more like an axoplasmic flow issue with fatigable weakness than, say, a peripheral neuropathy. Okay. The slow grade flow, much slower, 2 to 4 millimeters a day. This is something that's actually providing trophic nutrients and proteins for the end structures. So things that help to replenish. We always hear these people talking about like there's a whole new you every 7 years, right? Because your body regenerates these different tissues. A lot of these things are done via this slow anterograde flow. Skin, muscles, ligaments, any of these end organs that are innervated by some of these nerves. Um, Basically, what happens is as we start to lose this slow flow, it'll start to break down the end organ, right? So we can potentially get deterioration of, say, the tenomuscular junction, the tenoperiosteal junction. Um, and so that's a way where we can start having these innocuous events start to cause very significant structural damage, right? So somebody reaching into the back seat of their car, going to lift a backpack into the front seat, and pop, there goes the bicep tendon. That's not what we would consider a significant trauma, right? It's not high speed, it's not necessarily even high load, but these things do happen, right? And so in those sort of situations, we can start to kind of think about those things. Well, maybe there was a little bit of this slow grade um, axoplasmic flow disruption, and that end tissue in that bicep mechanism just wasn't getting the replenishment that it needed, and eventually those tissues started to degrade, and they just failed on you, right? So that's something that we have to take into consideration. There's no real good way to test for slow flow limit disruption. But if we have fast flow disruption, we can make the assumption that slow flow disruption is occurring as well, because they do occur together, both going through the cytoplasm of the axon. So it's still something that we can make the assumption on. Not really big on assumptions in those cases, but this is a situation where we can say, yeah, if we have one, we definitely are going to have the other. And again, we'll talk a bit more about some of the characteristics of these things so you can differentiate here when we get toward the bottom of this thing. All right. Next one, we're kind of moving away from the neurological components here and moving toward what we call neurophysiological issues. Okay, so segmental facilitation is a theory that was postulated by Ian Core way back in 1985. There is some literature on this stuff out there in the universe. It's not exceptionally well accepted by the medical community. I'll tell you that. So if you're
Mhm.
talking with a physician, mentioning things about segmental facilitation, they're going to kind of turn their nose up and be like, what the hell are you talking about? But I can tell you from, again, years and years of experience and a lot of objective findings, this is a phenomenon that does occur and occurs a lot in the body. Okay, so what this is, and it should be relatively obvious when you look at the name, segmental facilitation. It should be kind of obvious about some of the effects that this sort of thing causes. So what sets this off in the first place, this phenomenon, is persistent aberrant input into the segment of the spinal cord. There is a interneuron pool, okay, within the spinal cord of preganglionic neurons that are always kind of resting in a state of partial excitation. Okay, so the threshold that is required to get from a signal hitting this interneuron pool to the point where it actually depolarizes and sends out some motor output. When this aberrant input kind of rests within that interneuron pool, it increases the excitability of those nerves. Okay, and so it takes less stimulus to get the motor output to fire. Okay, so what that's going to do to us is it's going to increase the amount of tone within a particular muscle from that segment. Okay, so all the muscles that go across that segment of the spine. Okay, this will produce a very particular segmental and non-fatigable weakness. So this weakness should be very consistent regardless of how often I test it. Now I can make some arguments that if you test it too often, it's actually going to improve. But it should be consistent across multiple repetitions. Okay, so not fatigable, not getting worse the more often we test it. It will also produce a resistance to stretch. So if we have increased tone, it means that the muscle's not going to elongate as efficiently as it should because the tension on that contractile unit has increased substantially. Okay, it's what we look at as hypertonicity. There will be some hypersensitivity, or there can be some hypersensitivity to non-painful stimuli, meaning if you just kind of run your finger across the muscle, it might actually hurt. And usually that's associated with things like trigger points. But it doesn't necessarily just have to affect the muscle. It can affect the dermatome as well. So this could affect various other tissues, including skin, and joints, etc. Okay. The next one here, brisk reflexes. Okay, brisk, but not hyper-reflexic. Okay, this is a very important distinction, and one that can be very difficult to understand at times. So when I'm looking at a brisk reflex, it's what we would consider just an exaggeration of the normal reflex response. So it should be different from one side to the contralateral side. Okay, so if I'm looking at the patellar tap reflex, on, say, my right side, I have a very exaggerated response to what I get on the left side. Okay. A hyperreflexic response should be something that's more consistent with upper motor neuron lesions. And we should all be able to understand that right now, right? So the central nervous system essentially sits at a very high gain. Okay. And what I mean by that is if you look at somebody that's had central nervous system damage, so somebody that suffered a stroke, somebody that suffered a spinal cord lesion, somebody that has, MS or cerebral palsy or ALS, any of these sort of things, one of the most consistent things that we'll see with these sort of pathologies is they'll have spastic responses to motor use, right? So these sort of clonic responses where there's these cogwheeling moments, there's these repetitive movements that occur. It's very difficult to lengthen these things. And the reason for that is because there's damage to the descending reticular formation. Okay, the lateral reticular formation goes from the medulla down into the spinal cord, right? So we're looking at the reticulospinal tract, right? It tells us where it's going. But basically, this mechanism acts like a filter to filter out that high gain of the central nervous system so that we can produce fine coordinated movements with our hands, legs, etc., face, all these different things, right? So that we can write, so that we could draw, we can play the piano, we can, swing a golf club, all these different things that require fine motor coordination. It's that reticulospinal tract that is the thing that kind of allows us to do that by dampening the gain on the central nervous system. If there's damage to that structure, like I said, either by some sort of demyelinating condition, vascular response to, say, a stroke, or some sort of trauma to, say, the spinal cord itself, we lose that dampening and we start to get clonic responses or spastic responses. So a hyperreflexic response is very likely to have a very similar type of response to it. It's going to have the same sort of characteristics. We may get clonic beats that occur with the reflex test. We may get what we call radiation down through the remaining portion of the limb. So if I go back and I'm testing the patellar tap reflex, not only will I get an exaggerated, probably clonic response associated with the knee, I may also get a response out of the ankle as well as it starts to radiate down. These are, like I said, these very consistent hyperreflexic responses because we've lost that ability to dampen the high gain of the central nervous system. Okay, so that will not be the case. That is not what we will see with segmental facilitation. This is a normal reflex response, only exaggerated compared to either other muscles associated on the same side but in different segments, or the same segment on the opposite side. Okay. And we'll get into more stuff on how we're testing for upper motor neuron lesions as we go through the scanning examination and whatnot. That should be part of what you guys are going to go over coming up in the weekend intensive here in a couple of weeks. I think I'm seeing a lot of stuff in the chat. Hopefully Dave's helping me out with that.
I got you.
Got me. Cool.
I'm on it.
Good
You're on a
man.
roll. Keep going.
Orange peel skin is essentially, it's, if you look at the skin of an orange, it kind of has this almost like puckered characteristic to it. The orange peel skin there, what it is because we have this increase in tension of all the musculature, even some of the deep dermal tissue starts to kind of constrict. And so if you look at your skin and you kind of pinch it together, it's very similar, very similar appearance to that. So again, it has to do with the increase in tone as a result of the facilitation. Sympathetic tone will also increase. So this is associated with vasoconstriction, sweating, things of that sort of nature. So vasoconstriction will affect especially the smaller arterioles, things like that. People get coldness in their extremities and whatnot. But there is actually a test that we can do that associates with vasoconstriction that's actually relatively consistent. And the trigger points thing here at the very bottom. This is one of my soapbox moments that I have with facilitation. Muscles are reactive structures, right? They require input from the central nervous or from the nervous system in general. They require feedback from joint mechanoreceptors, from muscle spindles, from various different sensory receptors, Golgi tendon organs, etc. Muscles don't just decide to become tight. That's not something that's within, they don't have a mind of their own. That's not something that's within the scope of their ability, right? So when somebody comes in and they're just like, I'm just tight, there's a reason that they're tight, right? A lot of times it's an idiopathic thing, but it's something that we as physical therapists should be able to differentiate. Why did this get this way, right? Segmental facilitation is going to be one of the major reasons that we start to see these things. The trigger points, if any of you have done any dry needling classes or anything like that, where you're trying to actually hit one of these trigger points with a needle, those trigger points, what do you think they are? Those are the muscle spindles that have become wound up, right? It's the change in gamma neuron input. And so it's basically this thing has wound up because of that increase through the reflex arc that we're talking about through this pool of preganglionic neurons. And so when we hit that trigger point with the needle, it resets. And so that's why people tend to do so well with dry needling early on in the treatment mechanisms, because it relieves that tension. And those things can become painful over time, right? But it really needs to be caused by something. So if we're just using dry needling as a mechanism, this isn't to insult anybody that may have done this in the past, because I'm sure there's lots of therapists out there that are doing this still. We need to look for the cause of these trigger points, not just treat. The trigger point is the symptom, it's not the cause, right? So we need to be able to find these things and fix these things. And in most cases, it's going to be some sort of segmental dysfunction, right? It could be a simple subluxation of a facet joint. It could be a hypermobility of a facet joint, an instability. Any of these different things can cause this abnormal sensory input. Jim Meadows used to say that it had to be a nociceptive input. I never really bought into that idea. I do think this can be caused by abnormal proprioceptive or other, vibratory, any of these other sensory input mechanisms that the body has can cause this sort of feedback loop that winds this up. And I do want to make a point of using the term winds this up, because we should never mistake facilitation for a neuropathy, either radiculopathy or peripheral neuropathy. Neuropathies, they have everything drop down, everything diminishes. Strength diminishes, sensation diminishes, reflex responses diminish. Facilitation does the exact opposite, and it should make the name it on its own should make that obvious. It winds everything up. We have increased, more brisk reflexes. We have increased muscle tone. Okay, muscle tension still produces a specific type of weakness, which I'm going to talk about here in a few minutes, but it's an increase in tone as opposed to a decrease in tone, and an increase in sensitivity to touch, right? So that's the increase in sensory feedback. So again, facilitation winds everything up. Radiculopathy and other neuropathies drop everything down. So we should not be mistaking these two things for each other. And we'll go through probably a million different examples of this as we go through some of these courses. Again, here, why isn't this treatment number? There we go. All right, so the weakness associated, so as far as force output testing goes, the weakness that's associated with segmental facilitation is going to be segmental, makes sense, it's in the name, but also non-fatigable. So it should be consistent the more often we test it. This is the best thing that I can give you guys as far as differential diagnosis, in my opinion. Weakness with segmental facilitation tends to be velocity dependent, meaning how quickly I put the resistance onto that particular muscle affects the strength output. Okay. The theory behind this, and again, this is a criterion validity thing as opposed to a proven theory, but it definitely fits the pathoanatomical components of this sort of thing. The GTO, the Golgi tendon organ, is a sensory mechanism that's located within these contractile units, and its job is to sense tension across that musculotendinous unit, right? So if we're talking about a facilitation increasing the tension in all of the segmental musculature, then we're going to have increased sensitivity of the GTO, okay? What that means is the faster I put resistance onto that muscle, it's going to trigger an inhibitory response from the Golgi tendon organ, which is going to turn off those motor units. They're going to shut down, okay? The reason that it does this is it's a self-protection. It's a self-preservation mechanism. I always use this example. If there's a bowling ball sitting on a shelf above my head and it goes to fall and I try to catch it, but the ball is too heavy for me, as soon as that resistance, that weight hits my hand, it's going to trigger that GTO in that in my, say, biceps mechanism, and it's going to say too much. If you try and stop this thing, that muscle is going to snap. It's going to pop, and so it turns the muscle off to preserve the structural integrity of that musculotendinous unit. All right, so very, very consistent problem that we see with strength testing. Okay, so this is something that I can't tell you how many remote issues, meaning issues that are developed away from the site of a patient's pain, I've located because of this particular phenomenon, this speed-dependent phenomenon. It is so consistent. And it's one of those things when you show a patient this sort of thing in a clinic and you say, okay, this first repetition you can hold when I'm putting kind of slow, consistent pressure on this thing, it holds up just fine. But as soon as I start pushing quickly, now all of a sudden this thing's given out. And especially patients that want to be active, that want to do physical activities like running, jumping, throwing, swinging golf clubs, all these different things that require high acceleration, you can see how patients can cause themselves non-contact injuries potentially, right? So, one of the things that I always say is if I have a L5 facilitation and it's affecting parts of my hamstrings, I'm not going to get adequate co-contraction during running, jumping, cutting as an athlete because my hamstrings are going to be inhibited by the speed of this. Now I'm going to have abnormal an inability to produce adequate co-contraction across the knee. It's going to be much more anterior dominant, and that's going to potentially produce more shearing across the joint and potentially produce the possibility for more non-contact innocuous injuries, right? And we see these things all the time. People that watch sports, we see, football players running down the field, they go to put their foot in the ground and all of a sudden, pop, there it goes. Doesn't look like the knee goes in any particular abnormal direction. They're not hit, none of this stuff, but boom, it's out. This is one of the reasons some things like that can happen.
And I even saw a study from Turkey one time where they looked at this and they proposed a model that was a compression of the peripheral nerve endings coming across the tibia. And that compression caused this kind of inhibition, like axoplasmic flow loss, that instantaneous loss of control because of the damage from that local neural compression. I've never seen anything else on it, so you take it with a grain of salt, but it was within this model of they were proposing that, hey, is there some type of neural compression going on that decreases that proprioceptive input from the knee, and that's where they lose control. So
Yep.
not exactly this, but it fits into that model of these funny things you see.
Yeah, because everything can be explained. Just because we don't know how to explain it doesn't mean that it can't be explained, right? So hopefully this will kind of turn on a few light bulbs with you guys as we're going through this stuff. All right, we're out of the segmental components now. Okay, so all of those issues potentially have either multiple reasons for them being caused. Most of them are caused by spinal cord issues, right? So looking at radiculopathy, looking at segmental facilitations, consistently going to occur because of obviously radiculopathy. It has to because of the nerve root component. Segmental facilitation, most cases is going to be caused by a segmental issue. Peripheral neuropathy obviously is going to be a peripheral thing, but AXT is often going to have a spinal component along with it as well. But we're starting to get away from that stuff and look at more local pathologies. Okay, so reflex inhibition is something that happens at a local joint. Okay, so this is going to be non-segmental, and it's going to have a characteristic of a very breaking weakness. Okay, so again, going back to my ankle example, my ankle's up in dorsiflexion and I push down on it. It's going to hold for a second and then boom, it's going to give out. And it's going to tend to happen on the very first contraction. Okay, so if we're going to test repetitive times here, we're not going to get much past the first one because this is going to kind of override everything. Okay, this will be local, caused by a local problem, something at a local joint, and will typically affect all of the muscles that cross that joint. Okay, so there are some, maybe inconsistencies with that. If we look at something like the gastroc crossing the ankle, a lot of times we're just not going to be powerful enough to cause a true break of that particular muscle. But the inverters, the everters, and the ankle dorsiflexors, they're all going to have the same consistent issues, right? But when we're looking at that, we're looking at L4, L5, and S1, right? So again, multi-segmental issues tends to suggest that this is probably more likely a local pathology, particularly when it has that characteristic breaking weakness, okay? This is going to be caused by either abnormal feedback from the joint mechanoreceptors or inadequate leverage or mechanical advantage at that particular joint. So if I have, say, one of the most common ones that we see is the anteriorly subluxed talus, sticking with our ankle. That's going to affect the leverage, right? The ability of the anterior tib to produce an adequate lever. Okay, so we're going to have this thing just kind of give out. It's just not going to have enough strength to do it, mostly because it's just the mechanical advantage isn't what it needs to be. Okay.
Yeah, and you can think about this, your chronic ankle sprain patient, where you've seen all the research showing that, okay, these people have problems months later. You know, you see increased ACL or extremity injury influences in these people as well. Reflex inhibition is the local reaction. And then there's also, things in there that are more cortical influences driven by this. If this inhibition is occurring at the local joint, you could think of it being okay, it's a purely spinal cord, but then also consider that there's a cortical remapping that goes on that can also be involved in this as part of that rehabilitation. But you'll find this within this individual.
Yep. The other one that can happen locally is we've all seen is pain inhibition. Okay, basically this is weakness that's created by a pain response, right? And if it hurts to produce a contraction, odds are it's not going to hold up very well, right? So it could be caused by contractile tissue damage, local joint damage, or maybe swelling, or possibly a painful instability. Okay, will also present as a breaking weakness, but it should have a pain response associated with it, and that's how we differentiate it from just a simple reflex inhibition. All right, regional inhibition. This is the one that I was talking about before, regional dependence. This is our anchoring. This is the ability to anchor a particular joint either against the girdle or against the trunk, right? So functions very similar to a reflex inhibition, will cause a very similar braking type of weakness, usually on that first repetition, but it's caused by an inability to have a good foundation to anchor that musculature against the trunk or against the girdle mechanism that's supposed to be holding it. So if I were to test, say, the rotator cuff up here, external rotation of the rotator cuff up here at a 90-90 position, I may find weakness in this position, but if I bring that arm down and anchor it against the trunk, I may find that because I'm able to stabilize that against my rib cage, now all of a sudden I'm going to have improved strength, improved mechanical advantage, right? So that tends to suggest that it's something due to either shoulder girdle lesion, AC joint issue, clavicular rotation, or maybe even an upper thoracic lesion. And we'll talk more about how those things apply as we get into the courses, the weekend courses. Okay, so we should be able to test it the same way. We should find a braking weakness in one position, but we can then kind of try and do an anchoring either, by hand producing that, most common one would be stabilizing the SI joint by pushing the SI joint together and then retesting. So those sort of things are possible, and that's more consistent with a regional inhibition. But again, its characteristic is going to be this braking weakness, very likely on the first repetition. Oh, deconditioning. This is one I don't get into too much. It just happens to be in the curriculum when I'm going through this sort of stuff. So various forms of force generation that aren't going to be effective because the muscle's been underutilized, right? So this could be due to immobilization. Somebody has a significant fracture in a limb. They're stuck in a cast or a brace or a sling or something of that nature, and the muscle just starts to break down and we get atrophy as a result of that immobilization. Could also be because of a neurological insult. So say we actually have a trauma to a nerve, that can also affect the ability of the muscle to turn on. So we lose that tone. So same sort of idea. But this is not something that we're specifically looking for. It's usually pretty obvious when they're having these sort of issues with deconditioning. All right. So testing for these issues. I'm hoping I have enough time to get through all this stuff because this is very important.
I tell you what we're gonna do is we're gonna put the biomechanics, and I'll cover that during the weekend course that the Zoom we're gonna do next week. And this could probably do this one there. I think it'd be more important to continue this thread and take the time with it.
Okay.
Because they can review the biomechanics material and then because they'll be doing that, then I can go over to the weekend. That way you
Yeah.
can
All
kind
right.
of do this and we can continue on. That seem reasonable?
Yeah, that's good. So I'll
Okay.
just try and finish this up then.
Yep.
So what I use is a specific repetitive testing process. Okay. So something that you do consistently when there's an abnormality that's found, it stands out like a sore thumb, right? So if I'm consistent about how I do this testing process, when I find something that's not normal, it stands out to me, and then I can kind of interpret what that looks like, right? So, but it's very important because I think it can give us a very nice roadmap to determine if we have a neurological problem versus maybe a neuromuscular problem or a neurophysiological problem and or a mechanical problem, right? It can tell us whether or not we're dealing with a segmental issue or a local issue, right? And if it's a local issue, is it because of a pain response or is it because of a local mechanical issue? All of these different things, they point me in very specific directions when I find these sort of things going through this examination process. Um, I do think that we need to kind of look at this and kind of step away from the idea of simply grading a person's strength and look at using this output testing as more of a diagnostic tool. Okay, so it may only point you in a particular direction, but if it points me in a specific spot, then I don't have to spend half an hour or 2 weeks, half an hour in one session or 2 weeks over the course of multiple sessions trying to figure out where something's coming from. If I can get there on day one, oh, that makes me a much more efficient therapist, and it's definitely going to help that patient get better faster. All right, so here's the process. Each muscle that you're testing, you should plan on testing it about 5 or 6 times. So 5 or 6 repetitions. And that will tend to depend on what happens during the early responses. Okay, so the first 3 repetitions are done with a slow, consistent buildup of resistance. Okay, so we're not looking for speed dependence or velocity dependence with these first 3. Okay. we're really looking more for fatigability initially with these first three. However, if test one is positive, essentially if we find weakness on test one, it will tend to show up as a breaking weakness. Okay, and this will suggest either our reflex inhibition, pain inhibition, or regional inhibition. Okay, so it's going to tend to take us away from the immediacy of this is a spinal problem and move us toward this is a local problem. Okay, or in the case of regional inhibition, this is going to be more of a regional problem. Okay, it should affect all of the muscles that cross that particular joint. Okay, so then it should be multiple non-segmentally linked muscles, right? So we're looking at, for the shoulder girdle here, if we're looking at the glenohumeral joint, internal and external rotation, have different peripheral innervations. They also have different segmental innervations, right? So should affect all of those things, suggesting a local problem there. Pain inhibition should be associated with a pain response. Makes sense. It's in the name. And again, with regional inhibition, you should be able to negate that breaking weakness on that first repetition by helping to stabilize the limb either against the girdle or stabilize the girdle by hand, right? If that makes sense to everybody. Tests 2 and 3. So test 1, we're either looking for breaking weakness or we're moving into a repetitive test. Tests 2 and 3 are most likely to elicit that fatigable response, right? The ability to maintain a contraction or to produce multiple contractions, okay? This will tend to suggest a neurological problem, right? If we have fatigability, weakness that starts to increase over multiple repetitions, that suggests a neurological issue, either a segmental neurological issue with a radiculopathy, a peripheral neuropathy, or some sort of AXT issue, right? And again, we talked about this previously, but you have to test at least one additional key muscle here to make sure that it is indeed a segmental issue versus a peripheral issue, right? So if I'm looking at C6, for instance, I can test wrist extension and shoulder internal rotation. Different peripheral innervations, but the same segmental innervation, okay? AXT issues can be either segmental or peripheral, okay? That peripheral would tend to suggest a multiple crush issue. Segmental would just have to have more substantial compression of the neurological tissue here within the spine. But again, it's very unlikely to have things pop up with sensory testing or reflex testing in that situation. And again, we're very likely to have tension tests pop up as positive, either the slump, straight leg raise, or any of the upper limb tension tests. Okay. Again, fatigable weakness is the big thing we're looking for there. I will tell you again, it's very likely if you're going to have fatigable weakness, you're not going to get to the third repetition. It's going to be one repetition, they're going to be good. Repetition 2, it's going to be nothing. It's going to be almost limp by that point, just because there's not going to be enough carryover for us to find that as far as the number of motor units that are turning on. Okay, if we get through the first 3 repetitions, again, with that consistent slow buildup, without any positive findings, we're altering our method for reps 4, 5, and 6. We're going to be looking at velocity-dependent testing, okay? And this should be a marked velocity-dependent weakness, meaning it will pop up instantaneously on rep number 4, okay? You do rep number 5, it should still be there. Rep number 6, same thing, should still be there. Okay, so we're looking to influence that GTO and produce that speed-dependent mechanism. So when we find this, the next step then would be to look for other objectifiable signs of facilitation. Okay, trigger points within the segmental musculature. Local multifidi atrophy. So if I'm looking at an L4 mechanism potentially, I would actually go to L4 and look at the muscle tone of the multifidi, and it should be atrophied for the most part, probably because of local reflex inhibition that's occurring at that particular level. The scratch test, this goes back to the vasoconstriction that occurs with facilitation. If I run my fingers down the spinal gutters, basically just kind of scratching the skin, trying to elicit a hyperemic response, basically trying to get the skin to turn red, what we'll see, I kind of have to know where it is already. If I look right at that particular portion of skin and I scratch over it, what we'll find is there's a blanching spot, a spot that won't turn red because the blood flow won't adequately go into that, won't flush into the skin quite as quickly. I'll tell you this, it happens relatively quickly. So it actually corrects relatively quickly, where blood flow will come in from other areas, other watershed areas. But if you're looking specifically at it, you can objectifiably see that that skin won't turn red immediately. Okay. Maybe not the best test in the world, but it's definitely one that you can use. And then the wobble test, again, this is something that we'll go over in clinic. If you actually take that segment and you kind of just wiggle it around within a nice neutral range of motion, what it does is it floods that pool of interneurons with normal um, sensory input. And so what that'll do is it'll tend to dampen the facilitatory response. You can go back and retest that speed dependence, and it should be gone. It'll only be temporary, of course, but it will dissipate as a result of doing that sort of thing. So very interesting stuff. And again, something that we'll go over more consistently and make sure you guys understand when we get into the lab components. Okay, so this is just a summary. Test 1 is positive. It'll be a braking weakness, more indicative of reflex pain or regional inhibition. Test 2 or 3 is positive. It's likely a fatigable weakness due to radiculopathy, peripheral neuropathy, or an AXT issue. 4, 5, and 6 positive with velocity dependence. It's indicative of segmental facilitation. Okay, so that's my process. That's the way that I go through and do these things. And again, if I'm finding this, if I go in and I find a braking weakness right off the bat, I'm like, all right, my focus, at least for today, is going to be on that local joint, right? There's nothing to say that I can't have an underlying velocity dependent weakness that's underneath that, but I'll never be able to test it because this braking weakness is going to override the segmental component. Okay, and that is one of the limitations that we get with this. If I find a braking weakness on the first repetition, I can't test for any of these other underlying neurophysiological conditions because it's basically stopping me from getting to those repetitive tests. This is just another little aside thing. We'll usually do these tests in a shortened position of the muscle. So again, the ankle would be up in a dorsiflex position. The wrist would be here in an extended position. It has some specific scientific method to it. You can read about it here. But like grade 1 like muscle tissue strains tend to be found more consistently in a lengthened position. So if you're looking for more of a pain producer, more of like a diagnosis that this is a, muscle strain here within the forearm, you need to kind of be able to take that into consideration and change the position. Again, something we'll cover more consistently there. This is another issue, is doing manipulation or dry needling will actually improve a lot of these neurophysiological responses via the periaqueductal gray matter. It's actually a rush of blood that occurs in a specific portion of the brainstem that kind of gives us like a factory reset on that length tension mechanism. And so it will tend to eliminate any speed dependence. So if you go in and you treat something early on, you do a manipulation of the ankle, for instance, you may get a temporary improvement of speed dependence. So again, you can't necessarily test for some of these neurophysiological mechanisms after fixing a local problem because we're going to have this kind of neurophysiologic response via this vascular response in the midbrain. So again, minor limitations, but things that you can kind of take into consideration as you're going through your exam process and you get more comfortable with that stuff. So that's that, guys. A couple minutes over here, but hopefully that was worth doing.